All right, today I want to talk about a case where we looked at how head flexion helped us determine the cause of their vertigo responses. My name is Dr. Nathan Keiser. We have a chiropractic neurology practice here in Chelsea, Michigan, where we focus on helping people with neurological brain issues recover their capacity and get back to normal. So that's what we're talking about in this case here, where we had a gentleman had relayed that he had a vertigo episode after going to the bathroom at a urinal in a position where his head's flexed down for a period of time at the urinal. And then when he came up, noticed that he became disconnected, felt like his head was full of helium, started to have that rotational vertigo attack and had to go to bed, sleep it off, and was okay the next day. I want to kind of go through how do we kind of work our way through that from a diagnostic perspective. They're kind of two obvious things that we'd have to look at. So we have to differentiate, is this a vestibular problem? So a problem with the inner ear. And we know that in the anterior canals, we can have problems when people tip their head forward, or we can induce dizziness here. One of the ways that we can check for that is we actually use, they kind of look like VR goggles, but we can put them on your eyes and we can tip your head forward, and we want to see if it'll produce nystagmus. And that nystagmus will tell us if your brain's interpreting emotion that isn't there. So when I tip my head forward and I'm still, I shouldn't still have the continued movement of my eyes as though I'm kind of flipping in that position. So that's the one thing we can do. So when we check that, in this case, that's not the problem. So we're not having nystagmus. It's not reproducible with that anterior canal. But that leads us to the second component, which is going to be cervicogenic. In this case, we actually saw the dizziness and imbalance that they experienced was relative to head position. And when we look at that flexion of the spine, we kind of get just real simple. But if we think about that spinal cord coming from the brain and then traveling through a spinal canal, we want that canal to be wide open, so there's no chance of compression. In this case, what we see is because this particular patient has some stenosis around the cord, meaning the amount of space that's available for that cord to travel in is lessened. It's tighter. So when they flex their head forward and we create this sort of a posture, now that cord actually becomes blotted, where there's pressure that's put against it from the thecal sac. We get some fluid accumulation, and we see that in that period of time, we get a little bit of blotment in the cord. We create that cervicogenic component. We can see the other things that are be relative to that are changes in bowel and bladder function. We tend to see, like in males, particularly dribbling after urination. So women, it tends to look more like incontinence. But we can see those things as little subtle forms of myelopathy that happen not just in any posture, but particularly when we're in postures that irritate that spinal cord. And that's what we were looking at in this case. So we ruled out the vestibular component, but then we were able to reproduce that sensation with the head inflection, but not head inflection when standing up and tipping over, but actually laying down and putting them in that position this way, where we're not as worried about that gravity component. We're able to change the posture so we can isolate that neck in that position. We saw that was true there. And then to correlate that, we have a sort of a neck positioning device, almost looks like a traction device, where we can put someone's head in a more neutral position. And in that position, it was relieving, and we actually saw a relief of that feeling of pressure and helium in the head. So what does that tell us? It just kind of gives us a walkthrough, especially for people that notice when they're in certain positions that they're feeling dizzy or getting vertigo. We want to do that breakdown and to understand, is this something that is vestibular versus something that has a cervicogenic property to it, where it's something that's happening in their neck? And then how do we differentiate those treatments or even combine them? Hopefully that helps someone out there that's kind of been working through this or maybe wondering about it. If you got any questions, please send us an email and we'd be happy to hear more from you. If these are useful for you, send us a note. Let me know what kind of things are useful to talk about, and we'll be happy to do that. So hope it helps. Take care.